Well, thank you very much, everyone, for coming on this Wednesday evening to join us for our webinar. My name's Sam Wharton, and I'm a tissue viability nurse specialist for Coloplast. And I'm joined today with my colleague, Charlie, who will be manning the chat. So if you've got any questions as we go through today's presentation, please just put them in the chat. Charlie will answer them. And if we have time at the end, we can go through and have a little bit of a discussion. And if anyone's feeling brave, they can come on camera and talk to me. So hopefully you're in the right place and you're expecting a presentation today on wound infection. I'm just going to get the slides up. Here we go. From beginning. Okay, can everyone see the slides? Charlie, can you see them?
Yes, we can see them. Thanks, Sam.
Brilliant. So I'm going to get going, but I think people are still coming in. Like I said, please do use the chat function for any questions or comments you'd like to make. Like I said, my name's Sam. I'm a tissue viability nurse specialist with Coloplast. My background is a tissue viability nurse within the NHS for 13 years, working in acute community services. So I've got a breadth of knowledge around wounds. And today we're going to be doing Making Life Easier using Assess, Prepare, Treat with a focus on wound infection. So during the session this evening, we're going to introduce you to the Coloplast three-step approach. And this is a step-by-step framework to effectively assess, prepare and treat wounds, looking at infected wounds and biofilms. We're going to look at this simplified approach and we'll go through each step of this assess, prepare and treat in more detail. We're going to understand the impact of wound infection and biofilms on that wound progression and healing. We're going to gain an overview of the latest principles of best practice from the International Wound Infection Institute. And at the end of today's session, you will have the Coloplast three-step approach wound infection pathway to support you in your clinical practice. So we're going to just have a look at some of the figures around the burden of wounds. So if you're familiar with the work of Julian Guest, he's done a pivotal sort of study looking at the burden of wounds. And we know that from this study, 3.8 million patients are managed annually and have wounds. And we know that that money is forever increasing because we've got 3.8 billion wounds, but it's actually at a cost of 8.3 billion to the NHS on managing those annually. And this was data from back in 2017 and 18. And we know that those costs will be continuing to rise. So we're looking at over 10 billion pounds a year that will be used to manage these wounds. We know that it's estimated 59% of chronic wounds heal if there's no evidence of infection. And when you look at comparing that to the 45% that don't heal if there's a definite or suspected infection. So, you know, infection is causing a lot of issues to these patients and preventing that healing. We know that biofilm is a real challenge within clinical practice and that over 80% of chronic wounds will contain biofilms. And following a study, a questionnaire survey that was given to 2,000 healthcare professionals, just under half of them believe that wound infection is a challenge when treating wounds. And it can be challenging to identify it and to manage it and choose appropriate dressings to actually progress those wounds into healing and get rid of that infection once it's embedded in those wounds. So what is the clinical relevance of wound infection? Well, we know that on our skin, we've got microorganisms that sit there, but wound infection occurs when those microorganisms move deeper into the wound tissue and they start to proliferate, so they start multiplying, and then that therefore leads to those local signs of infection. They can be subtle signs of infection or those more classic signs, which we'll go into in more detail throughout this presentation. And if it isn't managed at that point, we can then continue to move deeper into the tissues and cause that systemic immune response as well. So it's also dependent on what microorganisms are within that wound as to the development of the wound infection. So when an infection is present, what does it do to that wound? Well, it delays healing. If a wound's infected, it's not going to progress, it's not going to heal. It really adversely impacts the patient's quality of life. When a wound's infected, there's often odour, there's an increase in exudate, there's an increase in pain for that patient. They're going to have that wound for longer. It may have a monetary effect on that patient because they're going to have to continue to go to the clinic. They might have to get taxis to get to clinic or to the practice. So that it has real impacts on that patient's quality of life. When we look at the treatment costs, like I said before, it costs £8.3 billion of NHS money to manage wounds. But when you're thinking of wound infection, there's going to be additional costs. And actually the costs aren't on the products. From the paper from Julian Guest, only 6% of that 8.3 billion is actually on products. The costs arise from the clinician's actual resource. So healthcare professionals going in to see the patient, that costs money. And when you're looking at infection, swabs cost money. I think it used to be about £50 for a swab when I was working in the NHS Trust, and I'm sure that will only just increase. There may have to be additional diagnostic tests. So if the wound's down to bone, having scans to check for osteomyelitis, they may need biopsies, they may need surgical debridement. All of these add to those costs. If there's systemic infection, they may need additional medication, so antibiotics, or if it's systemic infection, they could need IVs and admission to hospital. So again, it's all those increase in the cost to the NHS and those demands on the NHS, which just increase with wound infection. But with a holistic approach, a proper assessment and getting that early intervention, many of these problems can be avoided and the actual clinical outcomes can be improved. So hopefully following this session this evening, you'll have a bit more understanding and confidence to know those signs and symptoms of infection and how to manage it and progress that wound to healing. So at Coloplast, we have the Coloplast 3-step approach, which is a simplified approach to wound healing. It consists of 3 steps. So the step 1 is assessment, really paramount in defining those treatment goals. And within Coloplast, we have a framework that was produced with a panel of wound care experts, and we'll refer to this throughout this presentation. And it's called the Triangle of Wound Assessment, and it looks at those psychosocial factors surrounding the patient, the actual patient factors, so what age they are, what their mobility is like, what medication they're on, what other comorbidities they have. And then it looks at the finer detail of the wound, and it covers the 3 aspects of the wound. So that's the wound bed, the wound edge, and the peri-wound skin. So we'll go into this in more detail because we'll go through each step. We then move on to our step 2, which is prepare. So wound preparation is key, and it's something that I think as clinicians we've often skirted over and not given it the attention that it needs. But actually, when you do each of these steps, you really do get amazing outcomes for these patients with these static non-healing wounds, because you're removing those barriers to healing and you're creating that optimum healing environment. So that's why that step 2 is to prepare the wound. And the final step is treat. So through doing your really robust assessment of the patient and the wound bed, wound edge and peri-wound, preparing that wound to remove those barriers to healing, you then choose the most appropriate dressing that's going to manage the goals that you've identified for that wound to create that optimum healing environment. So, like I say, we're going to go through each step in more detail. So when we're looking at our assessment, what is our aim of wound assessment? Well, firstly, it's to actually identify the cause of skin breakdown. Without knowing what's caused that wound, you're not going to be able to progress it and heal it. So, for example, is it a pressure ulcer? What equipment do we need to remove that pressure? How do we need to position that patient to ensure that pressure is removed from the area? Is it a venous leg ulcer? Do they need compression therapy to ensure that wound's going to progress? So it's really important that you identify that cause of that skin breakdown initially. Then you want to look at those risk factors. So the patient's risk factors, the environmental risk factors that could be influencing whether that wound's going to heal or not. Correct and treat underlying causes. Again, when we think of wounds on the lower limb, it's about applying that compression, doing that full holistic lower limb assessment and identifying if there's sufficient arterial supply that we're getting that compression on to ensure that wound heals. Identifying appropriate management options, so seeing what the different options are. Maybe they need to be referred to vascular to have a more in-depth scan and see if there's additional support that the vascular team need to provide. Control those wound-related symptoms, so exudate, pain, odour. We need to be able to assess that wound appropriately and then manage those symptoms for the patient. Prevent that further skin wound deterioration. So that could be from excess exudate sitting on that surrounding peri-wound skin. We need to make sure we're managing that, assessing that, and making sure we're optimizing the healing potential. It's also about identifying the patient's expectations and managing that, and also giving them the opportunity to promote that patient independence and have them be involved in their care of their wound and provide that psychosocial support. How often wounds should be assessed? As a minimum, it should be every 2 weeks in an acute setting and every 4 weeks within a primary care and community setting. So that's doing that really full holistic full assessment. And we need to be doing it regularly to make sure we're actually recording and reviewing if wounds are actually progressing. And if they're not progressing, what have we missed? What do we need to recheck? Is there potentially a misdiagnosis? Do we need to be getting someone with more specialist skills in to review? So it's really important. Otherwise, what can happen is a patient can have a wound and it's just continued to be dressed, but it's not actually ever improving. We need to get wounds to heal. We should always be looking at wound healing, not wound management. So when we're doing our assessments and looking at our patients, it's really important to listen and look. So when we're listening, our patients are the expert in their wounds and we should listen to what's happened. It also helps build some confidence with clinicians if they're actually listened to rather than just looking straight at a wound without actually taking on what the patient's got to say and what's happened within their journey with this wound. It's really important to record all the current medications, and within that, making sure that you're recording what they're actually taking. So within a clinic I used to run, they used to come with scripts and we'd go through it when actually they were adjusting potentially what the medications they were having because they didn't like some of the side effects. So it's really just making sure that what they're actually taking compared to what's on prescription. You're also always looking. So as clinicians, I think we generally just do this without thinking. So you're looking at their age, you're looking at their mobility. Are they able to mobilize well? Have they got a walking aid? How are they? Are they feeling anxious? Do they look anxious, tired, confused? Are they sweaty? Do they have a temperature? Are they in pain? Something for me that I always like is to look at the previous dressing. So when I used to go on joint visits with district nurses, often they thought they were being helpful in putting the dressings in the bin. And then I'd have to go in and rummage because you can tell so much from the previous dressing. You can see the colour of the exudate, whether the dressing's containing the exudate, if there's any odour, So you really get quite a lot of information from previous dressings. And then you're looking at the skin. Is it dry? Is it dehydrated? Is there moisture present? Is there maceration? Do we need to manage that peri-wound maceration? Is there any skin sensitivity, numbness, burning, tingling? These sort of words that the patients use can actually give you some more ideas on what's going on with that wound. Odour, so undervalued, but has such an impact on a patient's quality of life. I have a patient that always comes into my mind whenever I think of odour, and it was this poor lady that was in a nursing home, and she had ischemic leg ulcer that was covered in necrotic tissue that really smelled. And the odour was so bad, she didn't want her family to come in and see her, but she had a palliative diagnosis. So we tried to do everything we could to minimise that odour, because she was progressing to that sort of end of life stage, but she didn't want her family to come in, and she was embarrassed, and it always sort of sticks with me. So it's really, you can't undervalue what odour does for a patient. You know, if you've got that really odorous wound, are you going to have an appetite? Are you going to want to see people, or do you want to become quite socially isolated because you don't want people to see and sort of be whispering or talking about you, or saying, oh, what's that smell? So, you know, we really need to do everything we can to remove odour, and bacterial burden within a wound does create odour. So we really need to be managing that as much as possible. So like I say, this is the triangle of wound assessment, and it's a holistic wound assessment to manage all the areas of the wound, as well as the patient and the psychosocial factors. So when we're looking at the wound bed, we're looking at the tissue type, the exudate, and any signs of infection. So tissue type, necrotic, sloughy, granulating, epithelializing. Exudate, again, like I say, it tells you so much about that wound. Is the volume low, medium, high? Is the exudate contained within the dressing, or is it actually breaking down the peri-wound skin because it's sitting on that edge of the wound? What's the consistency? Is it very thin and watery, or is it thick and purulent? What colour is it? All these indicate and give you clues as to what's going on within that wound bed. When you're looking at your infection, you've got those local signs of infection, so pain, erythema, edema, that warmth, that increase in exudate because the wound's in that inflammatory stage, delayed healing, that friable granulation tissue when you cleanse the wound, it can bleed really, really easily. Malodor, as we've talked about, odour and pocketing, and then those signs of spreading in systemic infection. So you're getting that erythema that's progressing past that 2 centimeters of that wound edge. The patient may have pyrexia. There may be abscesses and pus collections within that wound. The patient may have a general malaise. They often say, I just don't feel right today. Raised white blood cells and lymphangist. And then we look into the wound edge. So when we're looking at the wound edge, what are we looking at? We're looking at the maceration. Is there undermining? Is the wound dehydrated? Does it need moisture to encourage that devitalized necrotic tissue to soften, to allow that wound to heal? Or does it have really rolled edges? These are really complex to get rid of once you get rolled edges, and often end up needing to have some surgical intervention to actually progress them. So we need to look at those wound edges and make sure we're optimizing it as much as possible. If maceration's present, there's exudate sitting on that wound edge that's causing that maceration. So we need to look at what dressings we're using. Do we need to protect that wound edge with a barrier? If there's undermining, we also need to make sure we're recording it appropriately within our notes, so that the next clinician that comes is able to understand what depth it is and whereabouts the undermining and tunneling is. Dehydration, you're not going to be able to close that wound while that devitalized tissue sat in the middle. What you need to do is soften it to allow those epithelial cells to migrate across and close that wound up. Otherwise, they end up tunneling underneath. You can end up with really deep scarring, and it will obviously prolong that healing. And then we look at the peri-wound skin assessment. So again, you've got that maceration, but as well as it being around the wound edge on this photo, you can see it's extended down to the heel. So you're getting more and more of that maceration. And if it's not managed and not appropriately addressed, that wound's just going to get bigger and bigger because the skin will just continue to break down. Excoriation, dry skin. I'm sure anyone here who's removed TED stockings that have been on for quite a while, and you sort of get that snow globe effect as you pull down the TED stocking or hosiery, if they've got hosiery in place, you know, dry skin. It makes me want to itch just thinking about it, because, you know, it is really itchy when you have dry skin. Hyperkeratosis, really need to remove that, because again, underneath that hyperkeratosis, ulcers can also form. So it needs to be managed and it needs to be appropriately addressed. Callus, so this is a example of, obviously, on a diabetic foot ulcer. Podiatry will obviously, if it's a diabetic foot ulcer, will be involved in care, and they will provide that debridement of that callus. And then eczema as well. These are all things that you need to be looking at within that peri-wound skin to address and make sure we're optimizing for that patient. So who's at risk of wound infection? So we know it's a multifactorial, and it occurs when the cumulative risk factors overwhelm the patient. But some of the individual contributing factors are, I'm not going to go through each of these, but obviously if you've got poorly controlled diabetes, that's going to put you at more risk of infection, depending on what surgery, if you've had some surgery, medications you're on. And if you're malnutrition, again, and that's under malnutrition or over, it puts you at more risk of infection. Then we've got our environmental contributing factors. So obviously, if you're hospitalized, the longer you're in hospital, the bigger the increase of infection, unhygienic environments. So I used to be a community nurse, and I've been into some houses where hoarders have lived, and very unhygienic environments, and you know, you have to try and do your dressings as cleanly as possible, but it can be very challenging in some patients' homes. Repeated trauma, such as inappropriate dressing removal, if the dressing's too tacky and it's causing trauma, and then over time you're going to end up causing a bigger wound, and again increasing that risk of infection. So wound characteristics. So acute wounds, the type of wounds that are more prone to infection, so contaminated or dirty wounds. So if you're thinking, for example, a patient that's fallen outside on the ground, then that's going to be more predisposed to having infection, because it's going to have that dirty wound. Depending on operative procedures, if a patient's had for example, a skin tear and they've tried to manage it themselves, and that trauma with delayed treatment, again, because maybe it's been left open and microorganisms have been able to get into that wound, will then make it more prevalent for infection. Then you've got your chronic wounds. So obviously the degree of chronicity, how long has that wound been there? The longer the wound's there, the more susceptible to infection it's going to be. The size of the wound, the larger the wound, it's going to take longer to heal. Therefore, it's going to be more susceptible to infection, and also the depth. Again, wounds heal from the base up. If it's got a very big depth or cavity to that wound, it's going to take longer to heal. It's going to be more susceptible to infection. Also, whereabouts on the body the wound is. So obviously, sacral or ischial pressure ulcers are going to be more chance of infection just because of where they are in terms of fecal infection or fecal contamination. And then for both of them, any necrotic or foreign body will make it more predisposed to infection, impaired tissue perfusion, hematoma, and that increased exudate or moisture. Now we're just going to have a quick look at the International Wound Infection Institute continuum. So it's obviously 5 sections along the bottom here. So you've got your contamination, colonization, local infection, spreading infection, systemic infection, and then your biofilm across the top. And as you can see, from the left-hand side going to the right-hand side, that blue sort of slope moving up is that increase in the microbial virulence within that wound, which is causing more continuum towards systemic infection. So we're going to go along each of those. So your contamination and colonization is where those microbes are within that wound bed, but they're not proliferating, they're not multiplying, and they're not causing a reaction to that patient. But once we move into that local infection, those microorganisms are proliferating, they're moving deeper into the wound bed, and they're causing a response. The response is just localized to one location. And as they're multiplying, the signs and symptoms may be quite subtle, but then they develop into more of those classic symptoms. So your subtle symptoms are that hypergranulation, bleeding, epithelial bridging, that wound breakdown, the delay in healing, increased odour and pain. And then those really classic symptoms that we refer to when we think about infection. So that erythema, heat, swelling, purulent discharge, that delayed wound healing, and again, pain and odour. Then we're moving on to that spreading infection. So this is where the microorganisms are present within the wound, and they're proliferating and invading the surrounding tissues. So it's going beyond that 2 centimetres of that wound edge, it's spreading out. The patient will show those subtle and classic signs of symptoms of localised infection, but they will also demonstrate those early systemic infection indicators. And then we go on to our systemic infection. So this is really where the patient's at really high risk of being really unwell and potentially dying if they don't get the most appropriate treatment at this point. So we really don't want anyone to be moving into spreading or systemic infection. We'd like them all to sit at contamination or colonization. Prevention is always better than cure. So if we can be really vigilant and stop that progression along, then we're not putting that patient at really high risk of serious complications from infection. So when we're at systemic infection, the wounds affect the whole body now, and it's the microorganisms are spreading throughout the body, and that's via the vascular or the lymphatic systems. And the signs and symptoms are sepsis, organ dysfunction, and systemic inflammatory response. And then along the top, we've got that biofilm. That's that biofilm. It's a structured community of microorganisms, and they create this sort of chronic infection. The microorganisms produce this matrix, sugary matrix, to protect themselves, so that then whatever you use topically to try and remove them, it's not effective because they've got this lovely coating to protect themselves. They're not visible to the eye, but their presence is indicated with those sort of signs of infection. Also looking at the types of microorganisms in wounds. So we've got Pseudomonas. It's a gram-negative microorganisms, and it's a keen biofilm former. Over half of chronic leg ulcers will contain Pseudomonas, and it's characterized by those sort of larger sizes of wounds and that really slow healing rate. And it's got that real clear, distinct visual sort of a luminous green exudate, and it's got quite a distinct smell. So often you'll know that Pseudomonas is present through smelling it before you've even had a look and seen that sort of really luminous exudate. Then you've got your Staphylococcus. Again, it's a very keen biofilm former. It's a gram-positive bacteria. Healthy individuals, 30% of us carry it within our nose without any awareness. And the most well-known type is MRSA, which continues with a mortality rate of 28 to 38%. So swabbing, in general, swabbing should be done if one of the below signs is present, but obviously follow your own local policies and procedures within your clinical areas. But if there's acute wound with classic symptoms of infection, chronic wounds with signs of spreading or systemic infection, infected wounds that have failed to respond, and if you're looking for certain surgical procedures, then it needs to be swabbed to make sure that there's no specific bacteria that's gonna affect that surgery. So that was assess. it's quite a big subject to get through, and that was a very sort of quick overview. But as you can see, that assessment is very thorough, and to ensure that we're really correctly doing it, it does take some time, and it's really important that we do that to get that really holistic review of the patient. So we've done step 1, which is assess. Now we're moving on to step 2 in the Coloplast 3-step approach, which is prepare. So this is about preparing that wound to healing, removing those barriers that would prevent that wound from progressing. So we'll move on to prepare. So slough, non-viable tissue and biofilms can all delay that wound healing process. If you look at that picture on the right-hand side, you can see that's not a healthy wound. That's not going to progress. Those epithelial cells will not migrate across and close because you've got that devitalized tissue with a quite clear Pseudomonas present. While it's there, it's going to increase the risk of infection. Microorganisms love to hide and multiply within that dead devitalized tissue. They're getting all the little nooks and crannies. It gives them that perfect environment. It also inhibits the development of healthy tissue. While it's there, you're not going to get that lovely granulation tissue that we love to see in those wounds, and it limits the actual assessment, the visualization of what's going on in that wound bed. So when you're thinking of your pressure ulcers, for example, if you're not able to visualize to what depth of damage that pressure ulcer is, it may change your treatment plan depending on what category of damage you've got present. So it's really important that we are able to remove and prepare that wound to optimize that wound healing. This is a really interesting study that was, it was a retrospective study of 313,000 wounds. And it's just to illustrate that the more that you cleanse and debride your wounds, the quicker the wounds heal. So out of these 300,000 wounds, they just looked at just the diabetic foot ulcers, and they found that from all the study that they looked at, if a wound was debrided once a week, the mean time for that diabetic foot ulcer to heal was 21 days. But if it was only debrided once every 2 weeks, the mean average for that diabetic foot ulcer to heal was actually 76 days. So you can see that's a vastly longer time for that wound to heal compared to just once a week. So again, it's just reiterating and evidencing what we know, which is that if we cleanse and debride those wounds regularly, the wounds will heal quicker. So there's different types of ways we can prepare our wounds. So we've got that sort of general washing, just to remove any visual debris, feces, sweat. You've also got cleansing. So again, just removing any debris, bacteria, excess exudate. And then we move on to that autolytic debridement. So this is where you're choosing the most appropriate dressing to allow for that moist wound healing by allowing the body to break down that necrotic, devitalized tissue and remove it from the wound bed. Then we have mechanical debridement. So that's that physical removal of devitalized tissue using friction. So years and years and years ago, it used to be wet to dry gauze. So putting gauze, wet it, put it on the wound, let it dry out, and then rip it off. Obviously, we have advanced wound dressings now, and we have these debridements. So within Coloplast's portfolio of products, we have All Prep Pad, which is that mechanical debridement. It doesn't require extended competencies, and you're able to do it to ensure that you're optimizing that wound bed for the patient. You've also got maggots and larvae. So they like to eat the devitalized tissue and spit out enzymes that break it down. And you've also got enzymatic debridement. And then for those clinicians with extended skills and competencies and additional qualifications, there's also sharp and surgical debridement. But again, that requires additional skills and qualifications. So for international best practice management for biofilm, it's recognised that it's not a one-step solution, but it was also recognised that that first step is that wound preparation to cleanse and debride, to reduce the number of microorganisms by disturbing and removing some of those biofilms. So like I said, within Coloplast, we have All Prep Pad, and we've got a lovely photo there of someone's foot being cleansed and debrided with the All Prep Pad. So it's got a dark grey side and a light grey side. So the dark grey side is for disrupting and dislodging that slough and debris and non-viable tissue. And then the lighter grey side has this unique slits, so you can capture and absorb and remove any of that debris, slough and necrosis that's been disrupted. So like I say, in the international best practice management for biofilm and infection, it is to do that wound preparation. And then we'll go on to step 2 and 3 in a moment. So how often will wound preparation be required? Well, it's down to your clinical assessment. But as we've shown from that Wilcox study, the more that we prepare and cleanse and debride the wounds, the quicker they heal. And obviously that's our end goal for our patients, and to prevent infection. The quicker they heal, the less chance of getting infection. So you do it, you would do your assessment, you would use your clinical judgment, you would look at what your treatment goals are for that wound, that patient's pain levels, and choose at that point the frequency of that wound preparation. There are times when wound preparation, you either need to be cautious or get support from other specialists. So if a patient has a wound on the lower limb and is known to be diabetic, this may require some more specialist advice. If a patient has a known arterial flow concern or poor localized tissue perfusion, again, you may want to get some further advice prior to starting wound preparation. And if a patient's immunosuppressed because of medications, again, just take further advice or just be a bit more cautious for those patients. So we're going back to the Coloplast 3-step approach. So we've covered step 1, which is that assessment. We've just had a quick run through of that that wound preparation, using different types of debridement that are available, but obviously within the Coloplast portfolio that we have the All Prep Pad. And now we're moving on to treat. So by doing that really robust assessment, preparing that wound bed, we now know what our management goals are, and we need to choose the most appropriate dressing that's going to progress that wound and give that optimum healing environment. So we're moving on to treat. So it's really important that we create that optimum wound healing environment for the wound. So when you're looking, you need to think, what do we need to do? What do I need my dressing to do? Is there lots of exudate? Do I have exudate pooling? Do I need an absorbent dressing? Do I need to ensure the peri-wound skin is protected? Do I need to ensure there's no maceration? Or if there's excoriation, how am I going to manage that? I also need to look and see what the depth of the wound is. Is there a cavity? Do I need to use a filler? Or is it actually under 2 centimeters depth and I can just use one dressing with 3D fit technology? Is there signs of infection and biofilm? Do I need an active agent to ensure that we're addressing this and using that antimicrobial? But it's really also really important to identify and get that etiology of the wound. So you need to know that underlying cause, because that's integral to that wound healing. So we've gone through the international best practice management for biofilms and infections. So like we said, that wound preparation is step 1, but then it's about applying a barrier dressing that's going to prevent maceration by managing that exudate, taking it out of the wound and preventing that recontamination. And also your step 3 is that active agent to ensure that we're suppressing those biofilm formations. So biofilm continually reform. When we think about our teeth, we brush our teeth in the morning, we brush our teeth in the evening, but in between times that biofilms reform. And if we all run our tongue over our teeth, you'll start to feel that film sort of feeling over our teeth, and that's that biofilm reforming. It needs to be removed frequently, and then an active agent to stop those biofilms reforming. So when do we implement an antimicrobial? So when we're at contaminated and colonization stage, we just need to be vigilant. We just need to keep an eye on that wound, make sure it's progressing as you would expect, and no antimicrobials are indicated at this point. It's just about being visual. There's no bacterial burden. It's not causing any response to the patient. So like I say, it's not indicated to have an antimicrobial at this point. It's just to be vigilant and looking. But then when we step into that local infection, this is where a topical antimicrobial dressing is indicated. This is where we need to take action. There are those local signs of infection, be that subtle or those more classic signs, and we need to start thinking about what antimicrobial dressing is going to be needed to ensure that we're reducing those microbes and getting rid of them before we start moving along the continuum. And then if we're getting into spreading infection and systemic infection, then at this stage, systemic antibiotics will be required, but you still need to continue with that topical antimicrobial dressing still at this point, because you're still going to be able to reduce the number of microbes in that wound bed by using an antimicrobial alongside systemic antibiotics. So topical antimicrobials are available in many different forms. So they come in liquids, paste, creams, ointments, sprays, and impregnated dressings. How to use and the frequency of application depends on which product you're using. Some are used every day for a short period of time. Some require reapplications several times a day, and some can be left in contact with the wound for several days. So some of the common antimicrobials that I'm sure you either have on your formulary or have used within your clinical practice is honey, PHMB, iodine, and silver. So topical agents with silver have been used for thousands of years in wound care to prevent or to treat infection. Again, they're available in different forms. But over the recent years, with these advanced wound dressings, they're now available within the dressings. So that means that they're easier to apply, and they provide a sustained release of silver, which means less frequent dressing changes. So you're not having to continually reapply to get that antimicrobial effect. Silver has a broad spectrum antimicrobial effect against bacteria, both gram-negative and gram-positive. And it's also been shown to prevent that biofilm formation, which is why on the international guidelines, it's cleansing, applying a dressing, and then that active agent to stop that, suppress those biofilm forms. So silver targets multiple sites in bacteria. So it has 3 modes of attack. So mode 1 is the silver ions bind to the bacterial wall, and that therefore blocks that transport of substances in and out of the cell. Step 2 is when they're transported into the bacterial cell, they block the respiratory system, therefore destroying the energy production of that cell. And then it interacts with the DNA, so it stops that cell being able to divide and replicate. So it has these 3 modes of action. There's also the 2-week challenge. So to ensure that we're using our antimicrobials appropriately, we should use them for 2 weeks and then reassess to make sure that they're achieving what we need them to achieve. And if they're not, do we need to change that antimicrobial? So this is a simple flow diagram. So after 2 weeks, if the wound's improving but still continues to have signs of infection, then you can continue with the silver dressing. But just continue to regularly review to make sure it is still progressing. If there's been improvement in the wound and there's no signs of infection, then you can stop the silver treatment. It's done what you needed it to do. And then you can just continue to just be vigilant and watch the wound bed to make sure that it's not showing any signs of infection. But if after 2 weeks there's no improvement, at this point, this is where you would discontinue and consider a different antimicrobial agent. So at Coloplast, we like to make life easier. And with the Coloplast 3-step approach of assess, prepare and treat, it will really simplify wound healing to ensure these wounds are progressing. And ideally, we would like to prevent infection ever being present. And if you can follow these steps and do that really robust assessment, prepare and treat, you can prevent that. If infection is present, by doing assess, prepare, treat, you can then remove those barriers to healing, remove that infection and get those wounds progressing. So this is just a case study to go through where assess, prepare, treat really had amazing outcomes for this gentleman. So this is a 55-year-old male with type 2 diabetes and arterial insufficiency who had an amputation of his big toe. And before he was seen and started on assess, prepare, treat, he was having multiple dressings and daily dressing changed because the exudate levels were so high. So that's that picture one. So following the assessment, the management goals were to remove that non-viable tissue, to manage the exudate, manage the bacterial burden, protect the granulation and epithelial tissue, and to protect that skin. So through using assess, prepare with all prep pad and treat with Biatain Silicone AG, we then progressed that picture of day 1 to week 9. So you can see that is such a substantial change within that wound bed. It's reduced in size. There's lovely pink granulation tissue present. And actually at day 1, when he was first seen, they were actually talking about doing a further amputation. So, you know, it really was a touch point at which he was going to potentially lose more of his foot. But as you can see, by week 14, the change in that wound for a patient with type 2 diabetes and artificial insufficiency who was potentially looking at a further amputation, and to get that result within 4 weeks, again, it just shows what can be achieved with this assess, prepare, treat. So the wound decreased in size from 18 by 7 centimeters to 4 by 1 centimeters. The top of the wound where the toe was is now healed. The exudate levels remain eventually became quite low, and there were no signs of that localized infection. So the pain score was actually only 2 out of 10, and the wound no longer required that antimicrobial to manage the bacterial load, and it was just in the end treated with Biatain Silicone. So it's just another illustration of where that wound, that bacterial burden was really present within that wound bed, but actually by following assess, prepare, treat, the outcome for this gentleman was really positive. So like we said at the beginning, on the part of our objectives is to leave you with something useful to take back to clinical practice. So this is our simplifying wound healing, wound infection pathway. So it's quite self-explanatory. So at the top, we've got that triangle of wound assessment with our patient, the wound edge, wound bed and peri-wound skin. And so it goes down, is the wound infected? If it's not infected, we come across, is the wound progressing as expected? Yes. Granulation to the wound bed, just continue with your current treatment plan. If there's slough, devitalized tissue within that wound bed, prepare the wound for healing and consider treatment options. And you can refer to the product selection guide. So we have product selection guides for different etiologies of wounds. And when you speak to somebody following this event, you can ask for more details. If there's no signs of wound infection, but actually the wound's not progressing as you're expecting, then this could be where your suspected biofilm is present. So like we say, over 80% of chronic non-healing wounds will have a biofilm present. So if you've got that biofilm present, we need to be following those international best practice statements. So we need to be cleansing and debriding that wound and choosing an effective barrier dressing and using that active agent and doing the 2-week challenge with an antimicrobial. Going straight back up to the top again, is the wound infected? Yes. Is there signs of local infection? Again, we need to prepare that wound for healing and considering our treatment options and using antimicrobial for 2 weeks to see if that's effective. If there's spreading or systemic infection, is it sepsis, need to be referred on for urgent medical review, but continue to do that wound preparation and an antimicrobial treatment until so that then you're at least attacking it from both sort of ends to reduce that antimicrobial, reduce those microbes in that wound bed. And then at the bottom, you would always go back to reassess and make sure whatever you're implementing within your treatment plan is actually being effective. So this will be available to you following tonight's session. And on the back of this is a product selection guide, which obviously will just help you identify within the Coloplast portfolio what we have available. So step 1, assess. Step 2, prepare. So preparing the wound for healing using the All Prep pad. And then the treat. So within the Coloplast portfolio, if you've got a superficial wound or a wound 0 to 2 centimeters in depth, then we have Biatain Silicone AG or Biatain AG non-adhesive. So these dressings can form up to 2 centimeters, so you don't need to put a filler in because the dressing will actually conform to the wound bed, giving that antimicrobial, allowing that silver to work on those microbes and those biofilms to reduce and kill them. If it's more than 2 centimeters in depth or there's any undermining or tunneling, then you would use Biatain Alginate AG and then cover with Biatain Silicone or Biatain non-adhesive, because the active agent, the silver, is within the Biatain Alginate AG. You don't need to then put an AG product over the top. So those are the product selection choices that we have within Coloplast. We're very excited. This is the first time we're announcing this, but we're able to offer you a follow-up telephone call from our specialist team to discuss face-to-face or virtual education with yourselves, give you more details on our products and services. So there's a QR code there for people that are familiar with QR codes. If you scan it or click on the link in the chat, which Charlie hopefully has managed to put up there. I'm not very computer literate, so I wouldn't have a clue how to do that. But if you contact those, then the team will give you a call within the next sort of 24 to 48 hours, and you can ask for any additional support around our products and services. So really exciting new aspect following this educational event and support for yourselves within clinical practice. And finally, just going on to some other events we've got coming up. So next month we're doing our Assess, Prepare, Treat, looking at the etiology of pressure ulcers. So it's the same session, but 2 different times. So either the 6th of March or the 19th of March. Again, there's a QR code there if you want to scan it to log into the next webinars we've got. And we're also really excited because we've got our new podcast. So if you tune in to wherever you normally listen to your podcast, so Apple, Spotify, Google, I think it's on Audible as well, and search for Wound Care Conversations, we have some podcasts. So if you're out in community and you're driving between patients, or if you just want to have something in the background to listen to, again, it's just a nice way of introducing and sharing clinical knowledge. So we've got 3 out so far. One's on Assess, Prepare, Treat. One's on looking at Assess, Prepare, Treat and wound infection. And the last one is looking at pressure ulcers. And I think there's a 4th one either out or coming out, which is, again, looking at leg ulcers. So hopefully we've managed to cram quite a lot into the last hour. I'm going to stop sharing and come to Charlie and see if there's any questions or anything to discuss.
Hi, Sam.
Hello.
Brilliant presentation. Thanks so much for that. Lots and lots of people saying thank you in the comments and how brilliant the presentation has been. Very informative. I just want to reiterate to everyone, we will be sending you the recording of this presentation, and we will also be sending you a certificate for CPD, and lots of you asking for the pathway that will also be sent to you following this session. So there's been quite a bit of chatter throughout, Sam. Lots of sort of comments and questions, and I think I've answered nearly all the questions in the chat as we've gone along. But brilliant session, well done. That was great. Thank you.
Good. Well, thank you all for giving up an hour of your evening. And I'm pleased that it's been useful. And like I say, the Inside team will be contacting you for any additional support. But hopefully see you at another webinar or event soon. But thank you very much for attending.